going to be talking about making a diagnosis of coronary disease in the female patient population. What I want to do is walk you through some of the challenges that we encounter in this patient population. So why do we care? I think we all know in this room that obviously CAD is not just a man's disease. About 50% of the prevalence of disease is in the female patient population. And of course, more than 50% of the US population is female, so we'd better care about it, okay? The life expectancy in the female patient population is increasing. It's about 80 years of age currently. And about 33 million women in the United States are in the perimenopausal, postmenopausal age group, and clearly that's the highest risk patient population for female patients. And as I'll walk you through, making the diagnosis of obstructive coronary disease in female patients is very challenging, and for some good reasons. So we'll explore that. Cardiovascular mortality, the good news is that it has been on the decline. You can see specifically in the male patient population there's been a steady decline in cardiovascular mortality, not so much in the female patient population. In the last decade or so we've seen a decline in female patients. But the problem is, the downside here is that there's still an excess mortality of about 50,000 deaths on an annual basis in female patients compared to male patients from cardiovascular disease. So it's still an issue, and we still need to try and narrow that gap. Okay, let's talk a little bit about angina. Angina, this is a phenomenal study, a patient population study. 74 population samples. We're talking about close to 400,000 patients here from 31 countries. And what they were able to show was that the prevalence of angina in the female patient population is about 20% higher than the male patient population. So women out there have more angina than men. And if you look at all the various countries that were evaluated, it turns out that the female patients in the United States have the highest prevalence of angina, about 40% higher than any of the other samples or populations that were evaluated. So we have a real problem with the female patient population in the United States and trying to sort this out. So I think you're all aware of what is considered typical versus atypical and what we're now calling typical for female patients. So the typical substernal chest pressure, radiation down the left arm, shortness of breath, et cetera, is very typical actually for both sexes. But for female patients, angina does seem to be much more subtle. So the symptoms are less pronounced, they're milder. Sometimes you don't have chest pain per se. You may have just weakness, shortness of breath, fatigue. These are all symptoms that in the female patient population have become sort of the classic, typical symptoms for female patients. And that may actually contribute to the increased prevalence of angina in the female patients, and it may be complicating the story a little bit. So hand in hand with that, so we know on the one hand we have more angina in the female patient population, but going hand in hand with that, whether we look at patients with stable coronary disease, unstable coronary disease, non-ST elevation myocardial infarction, and even STEMI patients, we've seen systematically in all the trials that we have looked at that the prevalence of obstructive coronary disease is lower for female patients, significantly lower for female patients compared to male patients. So what's happening? On the one hand, you've got more angina. On the other hand, you've got less obstructive coronary disease. And we know that this is going to be influencing the outcomes of non-invasive tests. So what do we do to make a diagnosis of obstructive coronary disease? First thing you do is obviously take a very good history. You're probably all very familiar with the Diamond-Forrester classification. So I'm just going to walk you through that. Essentially, it's based on three characteristics. Number one, the substernal chest pain discomfort, so classic symptoms of chest pain and angina, the duration, the characteristics. Secondly, whether it's provoked by exertion or emotional stress. And then thirdly, whether it's relieved by rest or nitroglycerin. So those are the three factors. In their classification, if you had all three characteristics, that was considered and classified as typical angina. If you had two of the characteristics, it was classified as atypical angina. And if you had 0-1 characteristic, then it was considered non-anginal chest pain. And in their early validation, this is back from the early 80s, essentially looking at the prevalence of obstructive coronary disease on the basis of whether the patients were asymptomatic or whether they were symptomatic on the classification that they used. What you can see is if patients were obviously asymptomatic, the prevalence of disease is extremely low. And as you go into symptoms, going from non-anginal to atypical to then typical angina, you can see, particularly in the male patient population, the steady increase in the prevalence of coronary disease. For the female patient population, it's not as pronounced. So what you can see, even in those females with non-anginal classification, you can see that about 20% of these females, even more than 20% of these females, actually have obstructive coronary disease. So the symptoms in female patients are not as specific as in the male patient population. So what's the next thing we do? Well, we've been talking about all these non-invasive diagnostic tests. How do they perform in female patients? And how do they perform on the basis of the symptoms, the presenting symptoms? So clearly what we're looking at here is standard treadmill ECG, myocardial perfusion imaging, and stress echo. So clearly, all of these tests actually improve the positive predictive value. So having a positive test increases the ability or the diagnostic value by about 20% over and beyond what we find out by symptoms, whether it be definite angina, probable angina. The incremental benefit of doing a non-invasive test is about 20 percentage points. The downside, though, is the false negative rates. What you can see here, these are negative tests. If you have, again, we're talking about a female patient population here. So if you have a negative test and you have definite angina, you can see very high rates of obstructive coronary disease, so very high false negative rates. If you go to our guidelines, this is guidelines specifically for female patients, okay? This is from 2005. The recommendations are for female patients with both intermediate or high likelihood of obstructive coronary disease with either typical or atypical chest pain on presentation. The first line of non-invasive testing is your standard treadmill ECG. And again, I've shown you the false negative rates. Only if you have diabetics or patients with an abnormal baseline ECG should you go to a myocardial perfusion imaging. So again, first line, based on our guidelines, is to go to a treadmill ECG. To be fair, I just want to show some other data. This is another meta-analysis looking at both exercise MPI as well as stress echo, looking at the negative predictive value now for predicting cardiovascular death and myocardial infarction, comparing both men and women. And what you can see here in predicting cardiovascular death and MI, not predicting obstructive cardiovascular disease, you can see that it has a very high negative predictive value. Okay, so it's very good at excluding subsequent cardiovascular events. This is a patient population. We're talking about 400,000 patients. Landmark study published by Patel and published in the New England Journal of Medicine. Again, showing the patients being referred to the cardiac catheterization laboratory for the most part. So 62% of this patient population actually had no or minimal coronary disease. So what this speaks to is the fact that while the diagnostic angiography obviously does a very good job, it's the gold standard, we're not very good at pre-selecting these patients and referring patients, the proper patients, into diagnostic angiography. So why is this? And we can talk about this afterwards and get Greg's input, but I think there are a number of possibilities and reasons why this may be. First of all, many of the validation studies have been done in very well-controlled prospective studies using core laboratories, etc. And one of the questions is, what is the variation or the variability of these test results when you go in clinical practice and everyday practice? There may be very high false positive rates. There may be referral biases. And, of course, issues of exercise intolerance. So all of these, I think, in combination, I think it's multifactorial, lead to the fact that we are now over-referring potentially to cardiac angiography and seeing these results with 50 to 60% non-obstructive coronary disease when we look at the results following cardiac catheterization. All right, so that's sort of the background, the foundation. I want to talk a little bit about the PREDICT trial. Greg mentioned this earlier, but essentially this was the first prospective validation study for the test that he presented. So there were 1,160 patients in this study, and again, patients were selected on the basis of symptoms, suggestive of coronary disease, or they were asymptomatic with multiple risk factors. All these patients were referred into the cardiac catheterization lab for invasive angiography. And for the most part, about 70% of these patients actually had non-invasive imaging performed, so myocardial perfusion imaging. They were enrolled into the PREDICT trial. They all had their blood tests done, the chorus CAD blood sample, and then they went on to diagnostic angiography. And once again, the mechanism for identifying patients with obstructive coronary disease was on the basis of quantitative coronary angiography. And we did this, it was independently done. It was defined as a 50% diameter stenosis by quantitative coronary angiography. I want to reemphasize that this test is sex-specific. And if you think about all the non-invasive tests that are available out there, right, whether it be treadmill testing or stress echo or whatever you want to send your patient for, none of these tests are sex-specific. This is the only one that is. So it takes into account, number one, the age-dependent prevalence of obstructive coronary disease in female patients that we know and where that's pretty well documented. So what did we find? So this is essentially a sub-analysis of the overall PREDICT trial. So what we wanted to understand is, first of all, how does the test perform between the sexes, and what are the differences in terms of the predictive value of myocardial perfusion imaging? So first thing to note here is that the overall prevalence of disease in this patient population was 36. 36% of the population had obstructive coronary disease. It was higher in male patients, 47%, 22% in the female patient population. Again, reflecting what we know, the prevalence of obstructive coronary disease in female patients in any one of these populations is lower than in men, right? And then the other important factor is this age-dependent prevalence of disease. So, very low, about 10% up until the perimenopausal time frame, and pretty impressive here, this acceleration and catch-up, actually, to what we see in the male patient population. And obviously in the male patient population, very steady increase in the prevalence of obstructive coronary disease. This is just showing the same thing in a different way. We're looking at patients with minimal obstructive coronary disease, so the rate is much higher in the female patients compared to the male patients. It's about 70% of the population. And what we wanted to find out here is what are the clinical factors that actually predict obstructive coronary disease, and are they different between men and women? And what we found was that they were pretty similar. So what are the factors? Age, hypertension, dyslipidemia. You can see that in the female patient population as well as the male patient population. So it's really sort of the significant factors are very, very similar between the sexes. We were interested in trying to find out whether symptoms actually differ and predict obstructive coronary disease differently. And interestingly, once again, what we see is that in the male patient population, the symptoms are actually very predictive of obstructive coronary disease. You can see that the cases, these are the ones that had obstructive coronary disease. There was more typical, more atypical angina. But in the female patient population, it made absolutely no difference, non-significant. So the characteristics of the chest pain were really not able to differentiate cases from controls. We took that one step further, and we were wanting to find out the accuracy of this clinical risk score, so taking into account age, gender, and the symptoms. And again, what you can see by ROC analysis, you can see that in males, it's actually predictive. You can see the ROC is 0.66. In the female patient population, it's completely random. Essentially, the symptoms are not predictive whatsoever. Among the 70% of patients that had myocardial perfusion imaging, we wanted to take a look at how predictive this was. And I think this is actually very telling. Now, you have to understand that this is a biased patient population. All these patients are being referred to the cath lab. But interestingly, here in the female patients, you can see that of those with positive myocardial perfusion imaging, only 22% actually had obstructive coronary disease. And of those females with a negative MPI, 18% had obstructive coronary disease. So again, the performance is really not that great. In the male patient population, I guess this is a little bit more scary. If you look at those male patients with a negative MPI, actually 45% had obstructive coronary disease. So not very good. And of those with a positive MPI, only 35% had truly obstructive coronary disease. So the performance of MPIs in this study was really not great. We layered on top of the MPIs whether or not the symptoms help and improve the positive predictive value. And you can see that while in the male patients it does help, right? If you've got typical angina or atypical angina, it's certainly better than asymptomatic patients. Once again, making the point here, if you take a look at the female patient population, makes absolutely no difference. So the symptoms do not help. One of the important things is when you're seeing a patient in your office with symptoms, you want to be able to have a test. When the test comes back negative, you want to be able to say, don't worry, this is fine, you don't have the disease. So what you're looking at here is the negative predictive value, right? So what we wanted to do was to take a look at the negative predictive value and compare that from myocardial perfusion imaging versus the test. And take a look here. In the male patient population, the negative predictive value for MPI was 74%, slightly higher for the test. You can see the area under the curve was, again, slightly higher in the male patient population. But I think what's very striking from these data are the female patient population. Sorry about that. Where the myocardial perfusion imaging negative predictive value here was 75% and goes up to 84%. So it seems to be much more, much higher negative predictive value, much better at excluding obstructive coronary disease. And you can see here the area under the curve was very high. And I think that is what the value, specifically in the females, of this test.